Good morning, good afternoon, and good evening, everyone, wherever you may be joining us from in the world today. My name is Francesco Del Carpio, and I'm the CFAL York Operations Coordinator. I would like to officially open the fourth session of our AI for Global Health Challenges and Lessons Learned speaker series with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have longstanding relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Takaranto and has been caretaken by the Anishinaabeg Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation, and the territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event, our participants may be joining from various locations, so I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speaker, and our participants from around the world. Welcome to welcome to our webinar. Without further ado, it is my great pleasure to introduce our moderator, Dr. Blessing Ogbuokiri. Dr. Blessing Ogbuokiri is a postdoctoral fellow and instructor at York University, Canada. He has over 15 years of combined professional experience across a broad range of fields in academia, industry, and community-based organizations. He is a dynamic team player who is eager to utilize his diverse talents to advance in research and innovation. Dr. Ogbuokiri is interested in machine learning for health, data science for social good, social media computing, natural language processing, and theoretical computing. His goal is to actively collaborate with researchers in several interdisciplinary groups in using AI to help government and local communities to contain and manage the spread of community-based infectious disease outbreaks, such as COVID-19, malaria, and Mpox. Dr. Ogbuokiri, thank you for moderating today, and the floor is yours.
All right, thank you very much. Hi, everyone, and welcome to our fourth AI for PEP lecture series today. Before I continue, I'm going to be welcoming our speaker for today, and I would like to let us know the sort of house rules, what you're supposed to do today as a participant. So if you want to ask questions when the presenter is talking, you can actually send your questions or request whatever thing or observation or contribution to the question and answer section, or you raise your hand to speak. When he finishes talking, you can now, say what you want to say when you are asked to say so. Before we go forward, I would like to just give a brief hint on, this program is actually co-managed by AI for PEP and CIFAL, York University. And just for your information, just in a moment, I'd like to remind you that AI for PEP is simply the Global South AI for Pandemic and Epidemic Preparedness and the Response Network. And our general objective is to, strengthen equitable and responsive public health systems that leverage Southern-led responsible AI solutions to improve prevention, preparedness, and response to emerging and reemerging infectious diseases outbreak. And our specific objectives are to deepen the understanding of how to use responsible AI solutions to improve public health preparedness and respond to emerging and reemerging infectious disease outbreaks. And we're also programmed to, establish and support a multi-regional network across the Global South to address gaps in knowledge, capacities, and solutions. We also try to inform national, regional, and global policies and practices on the use of AI to improve health equity, strengthen public health systems. Now, I will go ahead to introduce the speaker for today. And also feel free to contact us, including the CIFAL York University or the AI for PEP team, if you wish. The speaker for today, or our speaker for today, is Dr. Stephen Gabriel. Dr. Stephen Alexander Gabriel is a medical doctor turned software engineer with a deep understanding of the interaction of health and technology. He has spent many years working in health technology companies, where he has gained valuable experience in applying technology to solve complex problems in healthcare. Currently, Dr. Stephen works as a software engineer at OpenMined, where he is focused on developing solutions to ensure privacy in health. Let us make welcome Dr. Stephen Gabriel. Dr. Stephen, over to you right now. Thank you very much.
Oh, thanks. That was a very grand welcome. Thank you, Dr. Blessing. And thank you for having me. Welcome, everybody. I pretty much have looked forward to this conversation for quite a while now. And so I'm just going to jump to it. I'm going to go ahead and share my screen, and then we can have a conversation. But before I do that, what we are going to be talking about specifically would be lessons that I have learned, and even my peers have learned from applying like AI to healthcare. And then with that being said, I'm going to go ahead and share my screen. And I suppose it's visible now. So I'm going to start with this particular quote, and that would be that the good physician treats the disease, and the great physician treats the patient who has a disease. And William Osler, if anybody knows anything about William Osler, he is one of the founding fathers of Johns Hopkins Hospital in the US. And why this quote is very important to me is that what we will be seeing today is that the patient, everything we're doing in healthcare, everything we want to do, we talk about is just patient focus. It's like, how do we make sure that we deliver like a very good experience to the patient? So we're more patient focused. So, and that way, it's my belief that if we do that, if that is our major focus point, we would make less errors and be more kind in our approach to things. So moving forward, so now the topic today is lessons learned from AI applications in health. And yeah, and this would be me just giving like a breakdown of several things. I would make it less technical, but more approachable for the audience to be able to like focus on like the human facing side of things, and also like the technical side of things, but in a way that all of us can relate to. I'm going to try to make it a little bit more interesting so that we can all follow along. So what am I going to talk about? I'm going to introduce this. I'm going to take some time to identifying use cases and data. This is, when you say AI in healthcare, what are we talking about? Like it can be a really broad area. Collaboration and teamwork, what I've learned with ethical considerations and biases, regulatory and validation challenges, change management and user adoption, measuring success and ROI, and in conclusion. And I will do my best to keep this way under 60 minutes mark so that we don't get all fatigued. This about me, pretty simple. I'm a doctor. It was pretty hilarious and interesting for when I heard Dr. Blessing, it's funny to say, oh, doctor turned software engineer. Most times I think myself more of an engineer than a doctor. Except when when I'm working on clinical processes, it just pops back in. I'm currently a software engineer at OpenMined. And I'm part of the core engineering team about OpenMined. OpenMined is just focused in solving privacy in AI. And I am currently leading partnership. And our main focus is, we have these, laser focus on AI privacy and healthcare data. And currently I am part of leading the partnership engineering engagement with most medical universities in North America, like Emory University, also in Europe, like Lille University in France. So because this is just like some partnerships going on and things I'm part of. Other things that you might find me doing is I really love software architecture. I like to design software. I like to nerd out on fundamental things like network and databases. So yeah, just throwing that out there. So introduction. Now, so today I want to just humbly delve into the realm of AI in healthcare, like a journey where empathy meets innovation. You see, this is very important because I don't want to say that we should not apply empathy to other aspects of other areas of life other than like healthcare, maybe like other parts or specialties, but empathy is very important when we're talking about healthcare. And together, let's just try to uncover the potential of this extraordinary technology. And then we'll share some laughter. And I hope you get to laugh. I mean, I can't see most of your faces, and then thoughtful reflections and on the experiences that shape our collective path forward. And moving on. The first thing, okay, to just give it a background, right? I can tell you for free that, correct me, maybe if I'm wrong at the end of the talk, healthcare has got to be one of the most delicate places you can automate, engineering-wise, right? And my foray into this, so when I was going to medical school, I didn't want to do conventional practice. I wanted to just jump into med school, and my aim was to solve healthcare with engineering. That has always been the goal, right? But I mean, when you start off, there's like a lot of things that goes on in your head. You want to write software, you want to build things. But down my technical route, back then in medical school, my experience in machine learning and AI became apparent. And then I went on to, in my fourth year in med school, I remember that there's a particular posting we used to do in pathology where, you realize that most times that you would watch how pathologists, go through like film of cancer slides just to reach a diagnosis. I'm like, oh, wait, this is something that, we could just probably like build an AI system around to give second opinion. And I want you to remember what I said by second opinion, because from the get-go, I am of the school of thought that artificial intelligence systems are complementary systems and not standalone systems. This can change down the line. I don't know enough futuristic mathematics to tell you that right now, artificial intelligence systems should be standalone machines. If I know enough theoretical computer science like Dr. Blessing, or maybe I've done lots of mathematical research in this area, maybe I can tell you futuristically or with boldness and with proof that AI systems can be standalone machine. But right now, I would think them not to be. So, and then I went on to build a system. Then in school, I called it cyber oncology. Realized that this is me looking for a use case, right? But, it worked. It did work at the time. But what I came to realize is that there are challenges I met, like data problems, access, even doing it right, proper feedback loop and all of that. So the first thing that was my first lesson when you apply AI to healthcare, you must actually find the right use case. And when I mean the right use case, the way I set off to build that project at the time was not the way it ended up being, because when I started building it, I went to get my supervisor, and he was a surgical pathologist. And then he says, this is the main challenge that we have as pathologists, right? You were viewing this problem from the lenses of a medical student, right? Because if the biggest challenge is feature localization, like if you're looking at a cell tissue, you want to be able to point at things and be like, okay, yeah, those are like red blood cells and all of that. So, and then I remodeled my use case, and then, to fit what I was trying to solve. So now choosing the right use case is very key. And to just throw this in here, one of the things that someone that wants to apply AI to healthcare should do is also to find like knowledge domain experts, right? And then when you're choosing use case, don't try to jump on bandwagons and be like, yeah, this is what's hype now. It should make sure that this use case is going to improve patient outcomes, streamline operations, and develop a healthy loop. So a healthy loop is that you have a way your cycle is complete. Okay, you learn kind of like a reinforcement learning, oh, this is not correct. So you have a way to learn from your mistakes and go back. Also knowing that, healthcare applications, especially software applications to healthcare, leaves you a little room for error. Moving on. Now, here's the next problem. And here's also the next lesson. I can tell you that one of the hardest things I've seen as an AI engineer or software engineer working in healthcare is acquiring quality data in healthcare. And it's not even because of availability. Is that I have not seen any field except maybe the military or the NSA or the FBI with all the secrets. But if you ever try to access medical data or want to do cross-institutional research, let's say you want to access data from, a good example would be, let's say, York University has a med school, and then you want to also access data from Harvard Med, and you're a data scientist wanting to do research, and you need their breast cancer data from York, and you want the breast cancer data from Harvard Med. It might be going well with you and York University until York University also learns that you're in partnership with Harvard Med. Like there is a lot of bureaucracy and policy around clinical data. And the reason that is that it's privacy, putting in so much effort to protect privacy. And now, that being said, most of medical data available are unlabeled. So you have data. Okay, fine. They've given you access to data. Okay, so, but it's not labeled. And data labeling in healthcare is very expensive, right? Because data labeling, for you to solve some healthcare problems, requires specialists to do that. And I don't mean you could, to tell you how simple this is, if you crowdsource, if you do human in the loop machine learning, where you, let's say you want to do something and you like what Google used to do, translate, I think Mozilla is doing it now. They're trying to gather data on text translations to be sure. And that is not, so if you put it out there, there are so many people that can speak your language. So if you're not available, someone else can give, feedback on or label that data for that particular use case. But if you throw out let's say a breast cancer slide image or a radiology image, or a mammography scan, it requires specialists, right? And what's going to be there is that problem is that you now have a slim pool of people that, okay, even if it's a large pool of people that know this, but where is the time, right? So that is also the next problem. Data labeling is so, and like I said, data is labeled of AI, but it's not always easy to find the right donor. And trust me, it's not always easy. And then you have to tackle privacy and security concerns, representative of data sets, clean it up, and then to ensure that the AI models are healthy and fit. Now, these are some of the things that anybody trying to build AI systems in healthcare needs to solve first. To solve this partnership, to figure all these things out before even the engineering starts. Now, let's talk about number 3, collaboration and teamwork. And if you follow through this talk, these lessons are layered in kind of like in an index, for progressive index form. So you probably notice, next thing you probably learn is, one of the things that I learned is collaboration and teamwork. Now, how did I get my project done, for instance? This is an internal project. I'm a student. I have all the security clearances to get, or I would say not security clearance per se, but, access to the data. It took me 2 months to be able to get proper access to this data, and took me about 6 to 8 months for the CDC department to agree to review my request. I mean, it sounds outlandish if you think about it that way, but it isn't actually. If you work in a very large organization, you would know that one of the biggest challenges or the bottlenecks is how fast requests move from the start of generation to response time, because of different hurdles that your request has to jump. But here's the thing: what do you get when you mix healthcare providers, AI experts, and regulators? You get a dream team, right? You get a dream team of AI in healthcare. And when you join forces, we can navigate the twists and turns of implementing AI and make the best decision for our patients and providers alike. Now, I want to also point out that as someone that has built AI systems in healthcare internally for an organization, for a startup organization that has their own data, and also worked in a place where we've tried to build AI systems in healthcare in a large organization that probably requires external data, they are weirdly and grossly very different, right? You'll be very surprised how much different it is, because if you are running a startup and you've curated data, some organizations will take some time to build their data, to build rich data source to build what they want to build, which might take a really long time. Then it's a different ball game when you want to use external data to build something. That is when you now realize that there are compliances you have to go through. I mean, every organization has compliance, and it's a lot in healthcare. It's a whole lot. Now, in fact, engineering is the least of your concerns while solving AI in healthcare. Engineering is the easiest. I guarantee you that the biggest problem that you might, or the biggest challenge you would face, is regulation, compliance, availability of the experts to help you to drive your dream home. But this is also a bottleneck and a challenge that needs to be solved. So if you are building something in healthcare and want to make very good progress and, not hit roadblocks, as if, or build in the blind, collaboration and teamwork is exceptional. Like internally, externally, make sure that you're working with partners that can help you, be sure that you're not breaking any laws, because it's just, I think the regulation around healthcare data is merciless, right? Like everybody's going to come for you. Literally, everybody's going to come for you. So one of the lessons I learned is how far collaboration and teamwork can get you. And then we're going to look at ethical consideration and bias. I am very, very particular about this. In the realm of AI, we must strive to be more like ethical superheroes. And our mission to protect patients' privacy, ensure consent, maintain AI transparency, while fighting the forces of healthcare chaos. I'm sure we have all seen the fast-moving trend of large language models. And there's another Luddite faction that says, hey, you need to pause large giant AI experiments. You're moving too fast, right? And what is the fear, if you ever think about it? It's because that I have not seen any tech that is as data hungry as artificial intelligence system. I don't know anything else. I don't know anything that. The other day, I saw a leak on Twitter that is saying that Google just started training their own LLM on 30 trillion parameters, and they hope to finish before Google I/O in May. Now, and then Google released a paper on MedPalm 2, which is like a large language model that, you know, has some clinical textual ability and can score over 84%, which is like really high for a clinical expert. It can answer all the questions on MedQA. Like it could, if anybody here is a medical student, it could easily pass your USMLE step 1, and even or any of the exams that are like, you know, give me a question, give me an answer. It easily can just get past it, right? And then, but the problem is, why do we have another faction saying, hey, slow down? This is probably, have we done all the ethical checks? Do we have the guardrails on? Are we doing something wrong with this? Now, it could imagine that GPT-4, because there's a classical technical difference between ChatGPT and GPT-4. GPT-4 itself is, you cannot call it a healthcare system. It's just a broad knowledge stuff, but you could see the fear. Now, imagine trying to build AI systems in healthcare and how much guardrails the world expects of you. Because patient data or clinical data is very, very private. You know, there is you, and then there is private data, and then there is clinical data. You know, like, it's a level of privacy, right? So yeah. So one of the things that I learned is that you need to at the beginning be sure that you are thinking about the patient. Is the patient protected? Is there consent? You know, are we doing something right? Are we doing something wrong? So these are like some of the last things that I learned. And one time I was working at a startup, and then we were building something. And then auditioning came. And then I realized that, oh, wait a minute. We are just going something against hyper compliance, which is like a compliance system for patient privacy and healthcare data in the United States. I think it also applies to North America as a whole. And then the project was, you know, like, came to a screeching halt to address ethical concerns first, right? And in my own younger mind, I didn't see what we were doing so grossly wrong at the time. It felt so, yeah, I was like, we have this data. But when the bubble and the whole thing was being explained, you realize that, okay, you need to actually like slow down, like really, really slow down. So the next thing is biases. I'm sure that most people have heard about the problem of AI bias. You know, if you know, AI is like a mirror. It can reflect our biases if we're not careful. Like, if you make there's a fundamental saying in statistics and any data thing, they would say the data can reflect your bias and assumption. In fact, you can build something that reflects your bias and assumption. Like, if you, I remember, you know, when there was a thing flying around at the time where this has nothing to do with me just like inciting something of race, but this is a classical case of bias. So if a model was being criticized then in China, and it's like, hey, look, if a fair-skinned person holds up a banana, he knows that it's a banana. But if you're a dark-skinned person and holds up a banana, oh, he thinks it's a gun, right? So the problem there is that the model might be thinking that if you're a black person and holding up something, oh, maybe you got a gun in your hand. So, you know, these are like classical things, because like, there was a particular time that most you know, like phone production companies that are in the Orient nation was being criticized. That is that they were criticized for how the AI in the camera managed images. So if you're like a person of color, and then it takes you and it snaps you, it tries to lighten the image, right? Like it assumes that you want to lighten the image. It's like, maybe you want to be lighter, right? So at some point, they wanted to like criticize algorithm fairness, like what assumption came about this. And yeah, so this is an actual thing. And then when you are building an AI application system that you're going to apply in somewhere as delicate as healthcare, bias is something that you have to be very careful about. One of the ways I've seen to solve this is to really, really check for the demographic that you're building for, right? A wide array of data would not hurt. And if you're building a global system, which is like really hard, right? You can, even right now, we have a proper healthy mix of people like, all over the world. So while you're building, be sure that you have a sound statistics on how you gather your data and how you are doing your modeling, and have experts, diverse experts give you opinion, right? This is why building AI in health, like applying AI to healthcare, is a very expensive process. It's not as straightforward as most people think. And this varies based on application anyway, but biases can actually be introduced without being careful. So the fifth one is regulatory and validation challenges. Now, how do you navigate regulatory frameworks? Jesus, healthcare is a labyrinth. Like, if you have ever tried to navigate it, for someone like me, I have seen it firsthand as a doctor, seen it firsthand as a medical student, seen it firsthand as a software engineer. There was a time that we had to, get a pass for a particular label, can't mention, but, working on something, and we needed some doctors to help in data labeling and data quality validation and all of that. The regulatory space took longer than the engineering time. So one of the things that you need to put into consideration as someone that is, or when you're applying AI to healthcare, is that you're going to have these problems, right? And then you're going to have to navigate regulatory frameworks. You're going to have to be sure that you're not doing something wrong. You're going to have to be sure that this system is designed in a way that maybe during auditing, somebody's going to be like, aha, see, or smash you with a lawsuit. And the next thing is, how do you validate what you built is right? Testing AI models is very rigorous, right? I'm sure that if you kept an eye out for kudos to the OpenAI team. Honestly, they proved to us that you can deploy, that AI systems can scale at a global level, right? I mean, most AI systems are used within, a small organization. Maybe sometimes they're not applied to super large scale, but now we're seeing that, great, it can be used, it can be deployed worldwide, it can be at large scale. But I think that the biggest challenge is that, when GPT, I'm using Chat GPT and GPT-4 because like that is like the most buzzing thing, and that makes it like really relatable. But you would see that there were many questions around the validation of the model. Why does it say things this way? Why does it do this? Why does it sound sentient? So validating your model is not like it's some of the things that you have to probably put into consideration. I found out that while building AI systems in healthcare, it works, but how valid is this? And then that's why I said that one of the best thing to do, and I'm going to say this is something about engineering. Let's say that what you built is good, but needs continuous improvement. One of the ways I've seen how to solve this is that there needs to be proper machine learning operation system that kind of like has like a cycle, mistake, learn, mistake, correct, retrain, feedback. So it's like constant cycle, because for every single, in fact, you see this also in most systems that you use, right? A good example is like reCAPTCHA. You see it sometimes even when you use systems that, smart system, like say a map, and it says, is this actually very correct? Or you try to use something like ChatGPT, it says, was this very correct? And you go thumbs up. Maybe you ask for something twice, and then it gives you 2 responses, and it asks, is this better than what I gave you the last time? And if it is, it learns, and then it takes, okay, better stuff. Let me learn again. So it's like to keep models. Okay, a good example was that one of the first places I started applying AI in healthcare was building NLP systems that would enable clinical assessment faster. So you have patients that come on this particular app and they want to, so the wait time for doctors took a lot of time, right? For human doctors, right? So we built this really interesting software and AI system in the middle. I called her Judy at the time. And then what Judy did at the time was, to reduce wait time, it's used the word like clerking. The initial clerking of the patient is done by that. And then when it does all of that, it arrives at a differential diagnosis, for the non-medical people. So if you arrive at if you tell a doctor a story of the thing that is wrong with you, they don't have a final diagnosis. You should not have a final diagnosis at the initial conversation. So you should have a differential, a couple of things that you believe might be wrong with the patient. So you see, the AI system handles this already. So, but it's, at the beginning, it would get it off. It would get some differentials like really, really off, right? And then we would, correct it internally because we couldn't leave that kind of stuff for the users to correct. So we had a 2-way system for like experts to be like, this differential is wrong. Maybe, so we retrain, we feed it back. So that way it got better at, the first baseline diagnosis, and then, and with differentials. So now change management and user adoption. I'm telling you that one of the things you might meet in your journey to applying AI in healthcare are people that are going to push back at it, right? There's something about humans. We are not as fast to change as we actually think we are. I mean, things get forced down our throat, and that's okay, we accept it. But you can see what's happening with every new tech. There's always going to be like, oh, what is this? I mean, there are people that never got to use the blockchain technology. I mean, blockchain technology is wobbly at the moment, but there are people that would never, ever want to own anything like a cryptocurrency. They'd be like, I don't understand this. This is crazy stuff. Doesn't make sense to me. I don't want to touch it, right? And then you have, we see the approach to things like even self-driving cars. It's like, this is madness. I want to be in control. I don't believe that I'm going to leave my car and then not touch it, sleep off, and the computer just drives me home. So now we need to find a way to embrace, in our inner math sciences. We need to learn, and you have these doubts too. You sometimes do have it, and then I feel like if you are working towards something like this, or maybe somebody's working with you to solve something, and you're in a position, you're either probably going to be the one accepting that, okay, this is possible. Let's see. Have questions, but we need to accept that it's possible for people to actually like move faster, with AI and healthcare, and then transforming patient care. The next thing is you're going to meet resistance. So change is scary, but AI isn't coming for your job, honestly. And then if you are the implementer and then you're the one building this, you need to find a way, the most kind way to explain this to like the people you're working, because look, nobody likes their job being taken. In fact, I remember one time when I was doing my project, then I was doing cyber oncology, and then my lecturer goes, "Are you saying that this system would diagnose cancer, and then breast cancer specifically, which is specifically my area of interest, would diagnose breast cancer and then reach a diagnosis without the need of a pathologist? Can this system know everything I have known for years?" I mean, and then I realized that this question can come in two ways. It could be constructive criticism, and also from a place of fear. Like, this doesn't make sense. Why do you want to build things that are going to just, throw humans away or do away with them? Now, what I always say is that, like I said at the beginning, now referencing back to that again, is that AI wouldn't take a job, right? I always tell them that I still see artificial intelligence systems as complementary systems and not standalone systems. We need to also have like human experts in some domains. Some domains can actually fully automate with AI, but I'm talking about healthcare, so I need to sit with that, because generally also humans, for some reasons, you get to trust. I mean, there used to be a joke back then in med school. They'd say, a patient would say, I can't, I mean, I'm Nigerian, so it's easy to assume that we have this strict sense of what someone that knows what they're doing looks like, So they would say, I don't trust my doctor if his trouser is not really big and his shirt is not really big. If he's too stylish, he doesn't know what he's doing, So, and there used to be this push for some people to like have their word codes really long to appear like these really hermit doctors because they're patient to gain patient trust. So we need to ease the fear of people that we're working with and show them how AI can help and is not hindering them from progressing. And then how do we measure success and return on investment? First of all, one of the things that I've seen in applying AI to healthcare is that conversations are not hard as to what success looks like. How do you know that what you build is becoming successful? Like, so success metrics from the beginning needs to be defined. Like, does it have a financial benefit to this? Be honest, be honest. Like, what is it that when you see, great. Are we, for instance, for the company I worked for, success was that we cut down the patient wait time almost 80% off. Like, the doctor has less work to do, like going back and forth, because it was a telemedicine system. And then it was no longer too long for them to communicate with their patient, right? And then it was like the smart system, the AI only gives the questions asked, the differential diagnosis, the patient data, and doctor looks like maybe ask a couple of questions, but it takes so long. It takes so short as at before the system was in production to move from, the patient coming into the app and then, getting done and getting a response. So that was success, and it was faster. And that also translates to money, because if you have people shedding and then winning or, running off because it takes a lot of time for them to see a doctor or get responses, you're going to lose customers. So that was success. So defining success metrics from the beginning while building AI systems in healthcare is very necessary, so that you know it when you see it. The next thing is tracking and communication. So good communication is like a well-choreographed dance. Everybody knows their step and moves in sync. There's a book. There's something I used to say about like working in organizations and anywhere. Your system reflects how much organization and communication that you have within your organization. I didn't learn this. I didn't generate this. I read it from a book, The Monolithic Man Month. And then it's like, if you build a software, and the user, if a user is out there enjoying it, that software is reflective of the level of homogeneity, or it could also show the entropy scale of like how much chaos is happening within, the range from collectedness, good communication, tracking, organization can show. So it's like applying AI to healthcare is a very delicate thing that I believe that only people that are very careful and like, willing to like communicate properly, and then, share progress, best practices. If there are things that needs to be communicated to the outside body, regulatory bodies, because when your product, this is what I'm saying, it's not simple. Trust me. Like, there is an ideal way a company should be, or an organization should be, but in the real world, there is just something about humans and how we handle stuff. But this is one of the challenges they're going to meet. And I think that it's something to put into consideration. And one of the lessons that I learned is that tracking and communication is like pretty useful. And then in conclusion of this, let's smile, right? This journey comes to a bit of an end. I'm a little bit, maybe like a bit of a 40 minutes, but just if you laughed, that's great. If you got some insight, that's great. And then, but I'm sure that I want to just show you the importance of teamwork, and then ethical AI, and then embracing change. Because these are the three things that I've seen that when you put into considerations, it's like one of the best lessons I learned. Like, if I want to build an AI system, it's not something you do alone. It's not a side project. If you want to build an AI system for healthcare, it's not a side project. You should do as much as possible to cover so many grounds in some of the things that I've talked about, and know that this is my personal experience. And I humbly state that I have a lot of journey ahead of me, and there are probably other things I didn't cover, which is like policy analysis around things like this. But but these are the things that I know that are core memory to me in applying AI to healthcare. So whenever your journey it's about to start in applying AI to healthcare, or wonder how these things are built, or want to ask questions, remember that you need a good team. You need to know how to be ethical, privacy, don't break anything. And then, embrace change, be able to carry people along. There's also a part of someone that might be like, oh my God, this is actually very bad. They're about to automate our job away. Find a way to for something like healthcare, it is not so simple to say one day a human, maybe in 2045 or 20, I don't know, because right now I'm so scared to even put a number to things, but maybe over time, maybe we'll enter cybernetic age that I can walk into a room and not talk to any doctor, and the machine does all these things, reaches a diagnosis, then operates on me, takes out, it would be so nice. I've thought about it. It's a good fantasy, but now let's find a way to work together. In concluding, thank you, and Tata Ovic. Honestly, this is a very stupid thing I learned from a show. I don't know if anybody saw Cheats. It's a show on Netflix, and there's this particular guy that always say Tata Ovic, and he's so sweet how he says it. And you can reach me through this email. That's my work mail at openmind.org, and 3 of my names, if you take out the underpart in Alexander. And then you can find me on social media at Bits of Steve, but calling me, I'm gonna think about that. I think before I go, one of the hot takes I want to say is that if anybody keeps up with FDA, I'm sure that you can see that there are a lot of like progress happening in AI in healthcare. There is there are about 500, more than 500 algorithms as of February that FDA approved. It's like 178, this was 178 in October, but as at February, I know it was over 500 or something. So these are like FDA approved like algorithms in different areas of, I'm sure that over the organizers are going to probably share this link if you want to take a look at it, but it's at health It's at it's at FDA, is a link in FDA. So it's like, and then what I found out that radiology is one of like the biggest areas of healthcare that is benefiting from advances in in AI in healthcare. And this is not strange to me, because I expected, because most of the time we have done a lot of advancement in image recognition, like an AI as a body, right? So many research. I mean, people were seeing that we're even enter generative AI, image generator AI with like things like Midjourney and Lensa and the rest. And now even with GPT-4, because it handles image vector understanding. And then you have, so radiology being an area that is, all about imaging, right? I'm not going to say it's no brainer, because it's not so simple, but you see that most of the algorithms you will see here are in radiology. Another area that is pretty prominent is cardiovascular. So it's great. I'm expecting that neurology would be the next place that we would see a lot of progress. Because specifically with things like studying brain waves and Fourier transform and Laplace transform with BCI, and something like EEG readings for like things like Parkinson and the rest, and Alzheimer's. So I'm expecting neurology, because we've made a lot of progress in brain computer interface, but like reading it and like transcribing it. So now this really brings to the end of this conversation. Thank you so much for taking your time to be here, and I guess I'm going to take some questions now.
All right. Thank you very much, Dr. Stephen. Thank you for your presentation. Interesting talk today. Just a recap of what Dr. Stephen just presented to us. He talked about access to data. I mean, it's very interesting to know that one of the things we are talking about here is about decolonization of research, especially in AI for paper and sci-fi. We've been talking about that, and it's quite interesting to know that decolonization of research will actually help in the access of data, especially in the healthcare. The issue of compliance, bureaucracy, and regulation will be reduced. This is one of the things that Dr. Stephen talked about. And the issue of collaboration and teamwork is very necessary, especially some of us some of the researchers or the teams in the Global South, where you might not have the kind of access to information or data that you need for your research. It will be interesting to actually collaborate with people, and that will help in fostering a proper research or a good result for your research. Then, meeting with experts as well. And he talked about ethical and tackling the ethical issues, tackling ethical consideration and biases. And, we had a lecture the other time in our last webinar where we talked about, the experts talked about biases. And he also made mention of that. So the issue of ethical issues, we in general in this space should try to strive to be more ethical when we are doing our research in this area, protect privacy and ensure consent. You don't take people's data without their consent or without the approval of the authorities. And you also talked about maintaining AI transparency while fighting the forces of health coercives. So we should also try to maintain transparency. And this is where also the decolonization of research comes in, where we are using locally generated data to build locally relevant models, to use locally generated healthcare data to also build or solve locally relevant problems. And that is more specific to that locality, without, maybe you want to solve an issue with that concerns a particular locality in Rwanda, and you are trying to use models that are built in the United States or in the Global South, then it's a lot of bias that you're going to be facing. So tackling the issue of bias, he also talked about being honest, really check for the demography, of your, or that you are trying to build. When you're trying to build whatever kind of data, you have to be very careful or consider the demography that you that you have in mind. There are myriad of data sets everywhere and diverse expertise that you can actually involve when you want to do your problem, when you want to solve the problem. Dr. Stephen also talked about regulatory frameworks, talking about validating AI models, talking about peak performance, talking about, have to try to follow thorough continuous monitoring and improvement in the models that you do. And there is also a need for proper ML training cycle. So regulatory frameworks are very also necessary and testing all these models. And last but not the least, from what I have here, I also talked about fostering innovation, which actually enables you to create a culture of innovation, inner mad sentiment. Is inner mad scientist, if I may call it, and encouraging experiment and learning, as the case may be. He also mentioned overcoming resistance. Change can be scary, of course, when you're trying to bring AI into any system, especially in the global south, because people might tend to be resistant to it because they feel it's coming to take their jobs. However, from this meeting today, we know that AI is not coming to take our job. It can be a complementary tool for us to improve in the things that we do, and also helps us to improve as persons or researchers. So we should find a way to, leverage on these technologies that is given to us, and we can actually use it to improve on what we know already. So he mentioned defining success matrices, when building AI model or AI systems. You should try and do that, and tracking and communication. So in conclusion, he said it's important to have a teamwork, to build a team or have a teamwork when you're building your AI in health, and also consider the ethical part of it. You don't just build, you should be mindful of the ethical considerations that are needed for you to build a standard AI model. And you also have to embrace change. Change is important, and it's also constant at all times. So at this juncture, I would like to I don't know if we have people that have questions before we, okay, do we have, okay, there are questions. So I'm going to be reading the questions, and I'll take them one after the other, then we'll get your feedback. So this question is coming from Esosa E. He says, the question says, how do you think the new implementation of AI, specifically LLMs, would affect developing countries like Nigeria without enough data? What options are available to implement these technologies? I guess you understand what LLMS is.
Yeah, large language models.
Okay, so large language models, exactly. So yeah, it's over to you now. Good, your answer.
Great.
Yeah.
Oh, thank you so much, Bless. I would want to ask you, how good were you in note taking in high school? Because you just took summary of the entire thing. I don't write notes, so however you did that is, for me, is very impressive. Like, how do you just?
That's why I'm here.
That's why you're a researcher and I'm not, right? Okay, great stuff. So I think that, I don't know if you want to approach this question, brutal honesty and all of that. There are several policy to answer Cesar's question. We are in Nigeria as a country, right? You need to understand that doing research, that is why doing research is a very expensive procedure. And that requires a fertile ground for that to happen. I'm going to give an example with OpenAI, right? Even in North America, not enough companies are even pulling off that level of research. Now, this is a very advanced country with resources and really smart people. Because one of the things that I've seen when it comes to AI research is that in the last 5 years, I started I saw like the importance of mathematics and engineering resurfaced all over. Like people just that are theoretical computer scientists and all of that, it resurfaced, right? And then research is not something that you know, it's not a short-term game, right? So someone like Nigeria, we have so many things we need to fix before we even become like major players in things like LLMs. One is that we don't have proper policy for scientific research, right? And if the government does not fix that and work with the universities to provide a fertile ground for us to be able to do this research, what we would see is that someone like the Global South, or Nigeria specifically, because that's what you asked, is that we would always be at the consumption side of things, right? Because this requires dedicated folks and really respectable knowledge experts and enough funding to sit back and do this kind of work. And then we need to, because I don't know how much quality of data that companies that are doing LLMs, I'm suspecting they have last quality data. I mean, we have Google and OpenAI. So we need to do this, but I think that how it's going to affect us is that right now we are going to be at the consumption part of things. And then because I don't think we have the workforce to do that level of research and produce out maybe LLMs or start competing at the global level. Yeah, that's what I think. And it's a lot of, there are so many layers of why we cannot just compete at this point. Yeah. Yeah.
Okay. I guess that answers Sosa's question. Thank you very much for your answer. I would like to take the second question for just a moment. Okay, so Janice Kumar Parasura says, very nice presentation. I am curious whether we have an representative data on AI for diagnosis. I am certain the data is not much represented from Global South, including those in AI lists in US FDA. This is Ganesh Kumar from India.
Yeah, that's a really good question. I think this is one of the reasons why I'm so grateful for organizations like Sci-Fi York and AI for PEP coming down the Global South, bringing up initiative for things like this. Global South is a little bit laid back in contemporary AI systems. Like if you want to know, if you dig through contemporary research, you will realize that we don't have proper data representation. One, we have very crude data sharing policies. Now, even in the modern world, there's still like a very strict policy around data sharing, but it's even way worse when you move around the Global South. So we don't have what is it called? Representative data as much as we should have. We will probably have here and there, but I'm going to tell you how you would know that we don't. If local universities in the Global South are not participating actively in that research, then we don't have representation. A good example is teaching hospitals. Let me talk about like Africa. There is no place you would find better, a huge amount of data than teaching hospitals in Africa. They have data, but if you look at researches done around AI in the Global South and then count how many of the teaching hospitals that are there and then compare the number of hospitals that are in the US FDA, you will now realize that how much you are missing out on. So we don't have as much as we should. Then what we should do is that our schools and major bodies need to start putting effort in representing, because they have this data and they need to be in partnership for this research. So yeah.
Okay, thank you very much for the answer. I guess that answers the question. So another question is coming from Chinedu Chubut. It says, could you cite any particular innovation ways that you have come across of collecting and aggregating healthcare data in Africa or similar contexts where penetration of electronic health record is low?
Great. And this is really good questions. Before I answer the question, I want to say that the biggest challenge we have in Africa is not engineering challenge to build these systems. We have policy problems. Specifically for Nigeria, for instance, there is the national policy for electronic health record has been with the government to sign it into bill for at least 3 to 4 years now. It's like, and if at a high level, we don't have a single a way the government manages electronic health record for patients, because to see the distortion, if you move from one hospital to the other, you will lose your user journey, or your patient journey ends with every hospital that you live in. In fact, locally, except it's a group of hospitals that are collaborating or group of bodies, data transfer does not even happen. Like, you cannot leave from hospital A and go to hospital B, and then your records are transported. Now, one of the ways that I've seen that, one of the creative and innovative ways that this can be solved is by using privacy enhanced technologies, right? Which is like that solve data economics, where bodies can join a particular network, and then the body that wants, like, let's say you are the startup or a company that wants to build something in AI, and then there are like 10 hospitals that you want to work with. There's usually, like, that's why the whole privacy AI systems are coming up now that allows those bodies, like those schools and organizations, to give you their data without privacy compromising their privacy, like using things like zero knowledge proof, differential privacy, federated learning, and and the sort of homomorphic encryption and sort of things like that. There are no straight innovative ways that I can see at the moment. It's pretty crude right now, because you either, like, it's so manual that you go from body to body, but there is no very innovative way for us to do that now that I've seen so much in Africa, except you have a data bank, a body that has collected so much amount of data from all these people, and then you become a subsidiary of them. And that is what I've seen. But there are systems coming up right now, which is part of what we solve at OpenMined to enable this to happen. Yeah.
Okay. Thank you very much for your presentation and for your response. At this point, I'd like to go to the next question, and it's from Pavel Arnold Njavwa Yumi, and he says, "Thank you, Doc, for your presentation. My concern is with the breast cancer. Is it possible to have data like density of the environment and predict whether people are at risk or not differently from image data? If so, could it give satisfactory results like that in radiology?"
Wow, that's like a really good question. So I can say that what I have seen, even in imaging in healthcare, is that you can arriving at best results or more confident results usually from augmentation, right? I am never a fan of I'm gonna put it right now, of using a single type of, I'm gonna use the word attack or method to say, if we can analyze density, then we can say, okay, you are at risk or not. I usually would want to do like an ensemble of different methods. I think I now that you answered this question, Yomi, reminds me that I probably missed out something in my presentation, which is like technical modalities, like what is the best way to grow confidence. The best thing I have seen in an AI model, especially with healthcare, is that if you can have multiple way to analyze and reach an answer or reach a confidence at a particular level, please take it. Yeah, I think I'm just going to keep it short, because it could give you a satisfactory if it could tell you whether it's the people are at risk or not. But remember that the entire thing about like AI in healthcare is to increase confidence based on like responses or like results that you have, because I don't think we've had getting definite responses or getting definite answers like pretty expensive. Yeah.
Okay. Listen, thank you very much for Pavel. I guess that answers your question. The next question is coming from Oluwafemi Adebayo. And he says, how can we encourage Global South governments to keep into the idea of MD, PhD, that's medical doctors in training for research purposes, that Canada is keen into for medical research?
Right.
You can, I don't know if, okay, yeah, go ahead.
No. See, honestly, this is the very good area for you. Blessing, please.
No. I am asking if you are in the right position to even answer the question, but you can go ahead because I mean it's a policy issue.
It's policy, yeah.
With the
I was gonna say policy, yeah.
government of Global South president, and I wouldn't know if they are looking into that. But if you have an idea and you can answer, this is actually a very interesting area to really explain more. We have medical doctors in our team that are into research, but I don't know how much of the Global South people or the Global South medical doctors that are into research or that are into what we're talking about right now. For academic and the AI for PEP, we have a medical doctor who is also one of our top researchers in the team. Okay, so this is actually going to be a very interesting area to find out, and it would be nice if even people in the audience, if in your country there is anything like this, then you can let us know. That would be interesting to actually harness this area. Okay, I would like to go to the next question, and this one is coming from, okay, this is also Dennis Kumar. So he says, Dennis Kumar Parasuraman. Okay, it says, so we need to build solid data from multiple data lakes by building a collaborative platform. That is for you, Doctor.
Yeah, we need to. And that is what PETS is solving now, privacy enhancing technologies. Is solving data economics like this. Yeah.
Okay, thank you very much. Edgar Oris Brizuela says, thank you so much for your talk. How should LMICs share data to validate application created elsewhere? Is there a recommended roadmap? Should LMICs be paid for data? Thanks in advance. I guess you understand what LMICs are.
Yeah, I think it's low and middle income countries.
Low and middle. Okay.
Yeah, right. So the thing now is I feel that low and middle income countries are like at a disadvantage because capitalist innovation does not even wait for you. We're not in a world of negotiation, right? If a company wants to build something, they'll find how to broker data from the low. Like a good example would be, I want to build something somewhere, I have money, I need data from Nigeria, I come here, I broker with a company, they hire people, they do it, right? Now, the reason is that the first thing is that the low and middle income countries should have a process by which, look at what like Europe did, GDPR, right? To protect data sharing. We don't have that most times in these low and middle income countries. So it means that somebody can actually broker your data and not tell you, and you don't get anything for it. Actually, first rule of Data Sharing Act is that the data owner should, I mean, for most of you that live in Europe, you would see that if you use a proper, if your data is accessed by anything else, your HMO tells you, they'll tell you, oh, this person accessed this thing. One is that keeping data trace helps you know when the data falls into someone's hands, especially like something like medical data. So to answer the question, like maybe we like how to share the data requires the government to have policies to make this possible. That's one. And two, and even if we say let's build a system, to do this, right? The problem is that if the system is not enforced with a legal backing, it means that an organization can also walk over it, even if it's existing, because guess what? I want to build something, I want to reduce bureaucracy. So first of all, the bottleneck is, yes, we should be able to, how should we share it? We could have used something like PET system to do that, or have like the concept of federated data sharing to do that. But can we do that as individuals? No, it's a teamwork thing. Is like the system needs to be backed legally. And is there a recommended roadmap? The recommended roadmap is that if the policy is instituted and the sensitization done, then the system should be built. So this is the 3 ways I know it's solved. And then, should LMICs be paid for data? I think so. I think that they should be paid. Data is not cheap. So yeah, that's my answer.
Okay. All right. Thank you very much for the question. We have 2 last questions, and I'm going to take the very first one, second to the last, from Rosalind Abba. He says, thanks, Doc, for your nice presentation. But how do we ensure Africans, especially Ghana, Nigeria, and other West Africans incorporate AI into healthcare? And can we give our all to ensure constant AI education in such settings to enable us migrate? So back to you, Doc.
That's a very compassionate and brilliant question. Now, the word ensure is very scary in the African terms, but let's just answer as if we have the right to use the word ensure. The way to ensure it is, you see, I believe in anybody did chemistry here, polymerase chain reaction or chain reaction, where like the work that AI for PEP and Global South is doing, people are becoming aware. So the talks about AI in healthcare is slowly creeping into our healthcare institutions. Rosalind, the biggest bottleneck we have are not private medical institution, actually the public medical institutions in Nigeria and Ghana. Let me give you an example. If you're in Nigeria and let's say there's a promulgation that says, okay, great, now all the teaching hospitals are now going to start using a smart system for XYZ. Oh, and it's not because the Minister for Health said it, it's because that the government, there's an implementation and there are resources to build this. Now, this is one way to ensure it. And you see, this somehow leaves our hand in terms of implementation, but what we're doing is the bit here, which is like sensitization, talking about it. You can also build something as an individual and then try to push the government, but it's always very much like a Sisyphean task. So yeah, and can we give all to ensure constant? Yeah. I am very all for, I think what AI for PEP is doing, Cypher Global South is doing is constantly just trying to educate for people in AI. Yeah, we can give our all, but there's just so much an organization can do. Yeah.
Okay, thank you very much. Thank you for the feedback. The last question here is from Adekunle Adewolo. Sorry for murdering your surname. Adekunle Adeluwoye. Okay. Do you see NLP research finding its place in West Africa, West Africa digital health, delivering for grassroots research soon?
Yeah.
Do you see NLP in that regard? Doctor?
Yeah, I do. I do actually. I worked in a couple of in Nigeria specifically. I worked in a couple of places that was doing NLP research and even NLP implementation, right? The problem is that NLP, I mean, Dr. Blessing is going to bear me witness, is that it's a very expensive area of research, right? Because there are a couple of people that have done some things. I saw some paper that was submitted to NeurIPS at the time, about like local language and all of that, and Pidgin and Igbo, whatever. And, just to constantly like do research in this area. So people are pushing, but like I said, research, not just NLP, research needs a fertile ground. And incentivization to be done. Like if the powers that are supposed to enable you to do that, or organizations that are supposed to enable you to do that, do not incentivize you, research becomes very painful. But yes, I see it finding its way to Africa and for digital health delivery, and it's going to be soon. I worked on a couple, that ran in production for quite a while, but yeah, so yeah, that's possible. Adekunle, that's possible.
Okay, that's it for us for the questions and answer section. Thank you very much, Dr. Stephen, for your time and for talking with us today for the lectures and taking your time to answer the questions. And I don't know if Professor Ali, is he available? Okay, if it's Professor Ali is not available, I don't know if Francesco, do you have the poster for our next session so that our audience should be able to have a look? So while he's getting that, you're mute. Okay, thank you very much. So our next session is actually going to be Dr. Crystal Moore. So you get ready and try to register. And our lecture series continues bi-weekly. In 2 weeks' time, we'll have Dr. Crystal to talk to us. And I will say thank you very much for your time, and I thank the SciFi team for helping us to organize and provide a platform for us. Thank also the AI for PEP team, and thank Professor Jude and Professor Ali for their support in this lecture series. From myself, Dr. Blessing Obokra, I will say thank you very much for your time and see you next 2 weeks, sorry. Bye for now. Please register if you haven't registered and endeavor to collaborate. Reach out to us if you have any question. You can also reach out to Dr. Stephen if you have questions. You can reach. The video is going to be on the website. The recording is going to be out in a moment, maybe in less than 1 hour. We'll share it on the website. Go to SciFi website and download it or watch it. If you want to contact Dr. Stephen, you can contact directly, reach him from the web or email address or his social media handle. Okay. And if you want to reach out to any of the teams, myself or Francesco or Dr. Jude, you can also reach out directly to us or our social media handles. Thank you very much for your time, and bye for now.
Bye. Thank you so much. Bye-bye. Bye.
Thank you, everyone. Thank you so much.